Okay, if you recall, the byproduct of metabolism that you have to get rid of for carbs and fat, the big one is CO2, right? And the respiratory system handles CO2. However, with amino acids have that amino group, that nitrogen-based compound. So when amino acids are metabolized in the liver, that amino group gets hacked off and gets converted to urea. So you can't breathe out urea, so you have to filter it out of your blood. In addition to the urea, you have small amounts of ammonia that you also have to get rid of. And that's important when we talk about the kidney and how it handles acid-base stuff. And then also through muscle cells, if you recall, I lied to you and told you that muscle cells store ATP. Remember that? I kind of lied. They store ATP in the form of creatine phosphate. And the byproduct of creatine is creatinine. And that has to be gotten rid of. So what the kidney really has to get rid of is these nitrogen-based compounds, so that's referred to as blood urea nitrogen. And then you have to get rid of creatinine. So those are the two blood tests that are really indicators of kidney function. And creatinine is by far the best measure because you make a certain amount of creatinine every day based on your muscle mass. So men's creatinine tends to be higher than women's. So those are the big waste products that the kidney has to get rid of. The other thing that the kidney does, so this would be number 2, is that it maintains fluid and electrolyte balance. Whoops. Now, I'm just going to say this, and then when we get into it, I'll be a little bit more detailed. The kidneys have a hard time filtering hydrogen ions and potassium ions. So the kidney has to actively secrete those ions into the blood. So if your kidneys fail, your blood will become acidic and your potassium levels will go up. So that's why in people who are on dialysis, one of the things that they will constantly measure is your pH and your potassium levels because the kidneys can't filter those. The other thing that the kidney does is that would be number 3, you can't see that, is you can't see that either. I'll make a good one, you can see this. It monitors O2 saturation of red blood cells. So as the blood is being passed into the retinal artery, or the renal artery, the kidney can monitor oxygen saturation of the blood. And if the kidney notices that there is a drop in oxygen saturation, the kidney will release a hormone called erythropoietin. That's a hormone that stimulates the bone marrow to make more red blood cells. So a lot of times people who are in kidney failure, they will actually have to get injections of erythropoietin in order to increase their red blood cell count. And this is important. As I told you before, when an organ fails, all the functions of that organ fail. So that's not good. The other thing, and we'll talk about this a little bit, the blood gas question that is on the kidney questions, you can just take that off, right? You can learn about that when you go into clinical. They'll teach you about that. But one of the things that it's involved in is maintaining pH, and more specifically, long-term pH. So we talked about this for quiz number 1, that the kidney can correct any pH disturbance if you live long enough. So if you can maintain blood flow to the kidney and kidney function when you're jacked up, you can do okay. You can correct that. The other thing that the kidney does, very important, right, this would be number 5, is that it activates vitamin D. Vitamin D precursor is synthesized in the skin. That precursor then goes to the liver and is further processed, and then it's ultimately activated in the kidney. And vitamin D is required to absorb calcium from your gut. So low levels of vitamin D can result in osteoporosis, all kinds of problems. All right, let's see. Boom, 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 boom. That pretty much sets up the functions of the kidney. You got me? Okay, now let's go over this. Hang on. You learned this in anatomy, so I'm going to give you a general overview, and just so we have a basis for discussion here. All right. What the kidney does is it filters the plasma of the blood. You got me? So the kidney is going to filter the plasma of the blood. The formed elements of the blood, the formed elements, should never show up in urine. So if you have red blood cells, white blood cells, or albumin in your urine, you're in big trouble. Your kidneys are failing. So once it's filtered the plasma, that urine then leaves the kidney via the ureter, and you got 2 of them because you got 2 kidneys, and then enters the hollow muscular organ called the bladder. Now, just so you know, the ureters are made of muscle. Just like the muscle that is involved in the GI tract, where it will rhythmically contract in a pattern, that is how urine is transported from the kidney into the bladder. It moves through peristaltic waves. That's why if you know anyone who's ever had a kidney stone, if that kidney stone lodges in a ureter, they don't have pain all the time. They get what's called renal colic, where the ureter is trying to contract that stone down, and as it contracts, that will elicit pain. So these people get these periodic, really nasty, sharp pains in their flank. That's renal colic. It depends, right? You can actually train your bladder to hold more urine, right? Women, for whatever reason, they can just hold an ungodly amount, right? They never have to pee, it seems like. But you can hold as much as a liter of urine, right? And it's like a ratchet system. You got me? So when the bladder's empty, the muscle's like this. And then as you fill the bladder with urine and you don't pee, then it ratchets down to try to relieve that pressure in the bladder. And then if the pressure builds up again because more urine gets added, it'll try ratcheting down again to relieve that pressure. And then finally, you just can't ratchet anymore, and then you gotta pee. But the longer you wait to go pee, the stronger that micturition reflex becomes. That's why after you hold it and then pee, right after that, you gotta pee a lot after that, because the reflex is continually stimulated. It's there's a certain truth to breaking the seal. Yeah, there is. Okay, tell me you followed that. All right, a couple of other things about the bladder itself. There are two sphincters, circular bands of muscle. You have an internal sphincter that is under autonomic control, and then you have an external sphincter that is under conscious control. So as the bladder begins to fill up with urine, right, in this case it's blue urine, as the pressure gets built up, it's going to initiate the micturition reflex, and that's going to cause relaxation of that internal sphincter. But you can tighten up that external sphincter and you say, yeah, I'm not going to pee yet. And then once you hit that critical pressure, it's going to open up and you're going to have to pee. Yes, they do. That's why they get dribbling or urinary incontinence, stress incontinence.
After surgery, they make you wait. Has anyone ever ruptured their bladder? After surgery, they tell you to stay and you have to pee or do this or that. You know,
not that, I don't know. I mean, could it happen? Sure. But here's the thing. Urine's always going to take the path of least resistance, and the only hole that it can get out of is the urethra. So what will happen is if the pressure gets high enough, it's just going to force open that urethra. And as people age, that external sphincter becomes weaker. That's why you see a little old man coming out of Denny's, out of the bathroom, and he's got a little line of urine going down his pants because it just dribbles out. It does. Women the same thing, right? They get older people get stress incontinence. So when you sneeze, you Valsalva, and that puts pressure on the bladder and causes you to pee.
How come some women, after they have babies, that happens too?
I don't know. I don't know a lot about that. Yeah. Well, if you read the textbook, that'll help. I'm thinking. Okay. All right. You got that? All right. So that's a general overview of the urinary system. Just so you know, just real quick, and you learn this in general too, but the ureters, they don't meet the bladder on top. They actually come underneath, and the urine bubbles up. So you're filling the bladder from the bottom up. All right. Okay, so let's go back to the kidneys. Now, this is really important. When an organ fails, all the functions of that organ fail. So when you're in kidney failure, all the functions that I just explained to you fail. Now, here we go. I'm going to tell you this, and then I'm going to try and show you. All right, so watch. The kidney does a couple of things to get rid of stuff. Number one, it filters the plasma. Number two, what you have to get rid of that cannot be filtered has to be actively secreted from the blood into the urine. You got me? And then what was actively filtered by the kidney, you have to reabsorb that stuff back into the blood. Now, the reason it's called reabsorb or reabsorption is because it was already absorbed from your GI tract into the blood. It then gets filtered out of your blood, and then you have to bring it back into your blood, so that's called reabsorption. So the kidney, and I'll get more specific in a minute, when they accomplish those three things, whatever's left over is your urine. All right. Now, this is really important. At least I think it is. The blood that is actually filtered by the kidney is arterial blood. The arterial blood is filtered. The reason the arterial blood is filtered is because the arterial blood's under pressure. So that pressure of the arterial blood allows for the plasma of the blood to be filtered. All right. Now, let's take a little bit closer look at the inner workings of the kidney. And again, it's like anything else. The devil's in the details. But if you understand this stuff, I got to tell you, it will make your life so much easier. All right, let's go over a quick anatomy of the kidney. Again, this is a cross-section of the kidney. And the kidney is really divided into three parts. It's divided into the outer part, which is the cortex of the kidney. Then you have the middle part, which is the medulla. And then you have what's called the renal pelvis, right? And this little yellow area, this is the urine's commons area. This is where all the urine meets, right? And then is drained from the kidney into the ureter. So, again, if you look very closely, you can see that as the renal artery enters the kidney, and another little anatomical term, any organ where large structures enter or exit that organ, that portion of that organ is called the hilum. So the hilum of the kidney is right here, because you got the ureter, renal artery, and renal vein entering and exiting. So as the renal artery enters the kidney through the hilum, as you can clearly see, the arteries become progressively smaller. And these arteries begin to climb up into the cortex of the kidney, and they terminate at the functional unit of the kidney. And the functional unit of the kidney is called the nephron. So the nephron is where the rubber meets the road. That is where the blood is actually filtered, and more specifically the plasma of the blood. So what I'm going to do for you now is take you on a little tour of the nephron. Now, if you remember from general anatomy, I explained to you the basic structure of the nephron, and now obviously in advance I'm going to have to get a little more complicated. All right, so a couple of things. First of all, the artery that takes the blood towards the nephron to be filtered is called the afferent arteriole. Afferent towards, right? Then that afferent arteriole terminates in this ball of capillaries. And this ball of capillaries is called the glomerulus. You can actually look, and glomerulus literally means, it is Latin for ball of capillaries. No joke. So, and this ball of capillaries actually is a little more porous than normal capillaries. They have these little slits in it, and I'll show you. They're called fenestrations. So this glomerulus is actually even more permeable than an average capillary. I think I have a picture of it. Maybe I don't. There's one in your book, to be sure. Fenestrations. So here's a blown up view of the glomerulus. Now look. The afferent arteriole brings the blood that is going to be filtered by the glomerulus. And remember, there's big stuff in your blood. There are red blood cells, white blood cells, and big albumin. And those things are so big that they should not normally be filtered by the glomerulus. So they should remain in the blood. So whatever is not filtered by the glomerulus exits the glomerulus through the efferent arteriole. And this is important. And as you can see here from this diagram, the efferent arteriole then leaves the glomerulus and forms a network of capillaries that surround what I like to refer to as the yellow brick road. So this network of capillaries, called the peritubular capillaries, in the peritubular capillaries, this is where stuff is secreted from the blood into the yellow brick road. For example, hydrogen ions and potassium ions, they have to be actively secreted from the blood into the yellow brick road. So again, secretion involves ATP, energy. So if your kidneys are failing, they can't filter those hydrogens and potassium, but if it's failing, you're not going to have any ATP to get these things out. So that's going to cause a drop in pH, and it's going to cause hyperkalemia. So they deal with metabolic acidosis and hyperkalemia in people who are in renal failure. Now watch. So the peritubular capillaries have to actively secrete stuff. Now watch. There's stuff that got filtered, right? It's not just all water. So the other function of the peritubular capillaries is to reabsorb the stuff that got filtered back into the blood. So the analogy that I like to use is that if you're going to clean your closet, what do? You go into your closet and you take everything out, and then based on what you want, you put back in. So what does the nephron do? The nephron filters all of the plasma, and then as it travels through the yellow brick road, it decides what it wants to take back into the blood based on the needs of the body. Say, yeah. This is going to sound crazy, but you know what? I got to pee like right now. Resume. All right, so watch. What urine is, or hang on, watch. How much blood do you pump each minute? 5 liters per minute. And at any given time, approximately 20%, 20 to 25% of the blood is going through both kidneys to be filtered. So on average, 1 liter per minute is being filtered by your kidney. And that means 60 liters per hour. Or in a day, that's 1,440 liters per day of blood is filtered by your kidneys. And clearly you do not urinate 1,440 liters per day. So watch. Even though 1,440 liters of plasma is filtered by the glomerulus and ends up in your nephrons, yes, 99% of it that was filtered gets actively reabsorbed. So on average, most people pee about 1 to 1.5 liters of urine per day. Now there's things that can affect that, either decrease it or increase it, but that's on average. So, having said that, There you go. Now, let's look at this for a minute. There are specific parts of the nephron, and each part of the nephron has a specific job, and I'll get into a little more detail. I'm going to give you an overview first. Now look, probably the most important part of the nephron is this guy right here. This is called the glomerular capsule. In some books, it's called Bowman's capsule. So it is the first part of the collecting tubules, the yellow brick road. And it completely surrounds, excuse me, completely surrounds the glomerulus, and anything that was filtered by the glomerulus will end up in Bowman's capsule. It will then travel through, this filtrate will then travel through this little convoluted tubule, and because it's closest to the origination of the nephron, it's called the proximal convoluted tubules. And the proximal convoluted tubules is where about 70% of the stuff that was filtered gets actively reabsorbed back into the blood. And how it gets actively reabsorbed back into the blood is through pumps, osmosis, and diffusion. So when you have to pump something, it requires ATP. So the cells that make up the proximal convoluted tubules are loaded with mitochondria because they need to make a lot of ATP to get that stuff that was filtered. You need to get that pumped back into the blood. Now, at the end of the proximal convoluted tubules, you can see where it begins to narrow out. And this little narrowed loop is called the loop of Henle. And you have basically two parts to the loop of Henle. You have the descending limb, and then you have the ascending limb. And in the descending limb of the loop of Henle, the only thing that can get reabsorbed back into the blood is water. And it works, that water gets reabsorbed based on osmosis, right? High concentration of stuff and low water in the collecting ducts, collecting tubules, and the opposite in the blood. And I'll explain more in a minute. Then, what's left over, that filtrate moves up the ascending limb, and the only thing that can be reabsorbed in the ascending limb is electrolytes, solute. Now this is important, and I'm not going to get into too much detail other than to say this. In order to absorb sodium from the ascending limb, you have to reabsorb back into the blood chloride and potassium. It's called a symporter. So it is like a little, think of a little elevator, that the only way the elevator is going to work is all three of these guys have to be on board. If any of these guys are not on board, these three ions will not get reabsorbed back into the blood. So, have you ever heard of Lasix? Have you heard of that? That's referred to as a loop diuretic because it affects the loop of Henle. Actually, how it works, and that's very good, it actually, Lasix prevents the reabsorption of chloride back into the blood. And if you can't reabsorb chloride, what won't follow? And sodium has the osmotic effect, so it will draw water from the blood into the collecting tubules. So as you pee out the sodium, you also pee out the water. The problem with that is that you also pee out the potassium as well That's why Lasix is a non-potassium sparing diuretic. And people who are on Lasix have to monitor their potassium because their potassium levels can drop quickly. Did you see that?
That makes sense.
What's that?
That makes sense.
Yeah, it does. Makes perfect sense. When you get into clinical, they're going to tell you that it's a loop diuretic and that you have to monitor their potassium. Ain't that right? All right. Now watch. What's the only thing that can be reabsorbed in the ascending limb? Those are electrolytes. You got me? Now as you can see here, you can see where the little thin loop of Henle, it thickens out, right? Right here. And this portion, and it's called the thickened ascending limb of the loop of Henle. Limb. Got me? This is where electrolytes are actively pumped into the blood. Boom. So, if you look, and I'm just going to tell you, in this portion of the collecting ducts, right, the yellow brick road, the only thing that can get reabsorbed back into the blood, and does, are electrolytes. And if you recall from quiz number 1, I explained to you that the osmolarity is stuff over water. Therefore, if water is impermeable to this portion of the ascending limb, but only stuff can get reabsorbed back into the blood, that will cause a decrease in stuff, and if the water stays the same, that will cause a subsequent decrease in osmolarity. So the osmolarity of the urine, or what's soon to be urine, now enters the distal convoluted tubules and is very, very dilute. So the urine that you produce that ends up in the distal convoluted tubules is very dilute. And your kidney then decides, am I going to make a dilute urine today, or am I going to make a concentrated urine? And, you know, the kidney thinks about it. This, in the distal convoluted tubules, this is where hormones exert their effect. And the 3 hormones that have the most profound effect on the kidney, and specifically the nephron, are ADH, or anti-diuretic hormone, ANP, atrial natriuretic peptide, and aldosterone. These 3 hormones work together, and they're released based on different stimuli, but their primary effect is on the distal convoluted tubules, and to some degree, the collecting ducts. Now, in the absence of hormones, whatever ends up in the collecting ducts is going to be your urine. And if you look, if you go back here, if you see this, let's get rid of this a minute. I'm going to blow this up just a touch for you. if you look at this, what you're looking at is the nephron. Here you have the glomerulus, Bowman's capsule, proximal convoluted tubules, descending limb, ascending limb, the distal convoluted tubules, and then finally the collecting ducts. The collecting ducts then dump their urine into the renal calyx or cup. And all of the nephrons from your kidney dump their urine into the calyx, the cup. And then that urine is then subsequently drained into the ureter and then into your bladder. You got me? Okay. Now, let's look at this. So what I'm going to do for you is I'm going to first explain to you the stuff that is in urine, and then I'm going to explain to you how the hormones affect the kidney. But before I do that, I have to explain to you this. Hang on a second. I'm going to get this right. Okay. One of the unique properties of the kidney, I find this kind of fascinating, is you could literally draw a line through the kidney. Let me just do this and then it'll make more sense. That should be straighter. You know what I'm talking about, right? All right, watch. The osmolarity within the cortex of the kidney is about 300. As you move from the cortex of the kidney deeper and deeper into the medulla of the kidney, the osmolarity progressively increases. 600, 900, 1200. So as you move, as the nephron moves deeper and deeper into the cortex of the kidney, they're seeing, the stuff that's in the collecting tubules is seeing a saltier and saltier environment. More stuff and less water. So the osmolarity is going up. So if you look here, let me make this just a little bit bigger. So watch. $300 600, 900, 1200. So the osmolarity as the nephron moves from the cortex into the medulla is going up. That means the blood, the peritubular capillaries, has an osmolarity of 600, 900, and 1200. You following that so far? All right. Now watch. The stuff that should be in your urine, of course, water. Electrolytes, right? Vitamins, especially water-soluble vitamins, right? You're going to have ammonia. You're going to have urea. You're going to have creatinine. Now, if you recall from the first day, I'll never forget it, I said that through metabolism, your cells of your body produce hydrogen ions. I remember saying that very distinctly. Therefore, you're making acid. And what controls pH? The kidney does. So the kidney has to excrete that acid. And how it does it is bicarbonate is readily filtered by the glomerulus and ends up in the collecting tubules. So how the kidney maintains the pH of the blood is by secreting hydrogen ions into the collecting tubules and then reabsorbing bicarbonate that was going to get peed into the toilet back into the blood. Do you follow that? Are you with me so far? Now, glucose is small, and you should never have glucose in your urine. That's because 100% of the glucose that was filtered by the glomerulus that ends up in the collecting tubules gets reabsorbed back into the blood. However, there is a renal threshold for glucose reabsorption, and it is typically 180 milligrams per deciliter. So if your blood sugar is over 180, and it never should be unless you are diabetic, you should never have glucose in your urine. If you do, then you're diabetic. And the higher the amount of glucose you have in your urine, the higher it correlates with what your blood sugar actually is. So there you have it. Those are the big things. Crystals of glucose? No, those are usually called CAS. When calcium will get dumped into the urine, and calcium combined with compounds called oxalate, urate, or citrate, and that can form a precipitate.
Can you actually see the crystals?
Yeah, under a microscope, but you can't see it, naked eye. Okay? Yes?
So which one is it the convoluted tubule that has the high osmolarity or the...
No, it's the peritubular capillaries in the surrounding interstitium within the kidney. That's a very good point. All right, so here we go. Ready? The osmolarity of the blood is about 300 milliosmoles. And what is filtered by the glomerulus and enters the proximal convoluted tubules, that has an osmolarity of 300 also. Now, if you recall, I explained to you that the proximal convoluted tubules is where 70% of the stuff that was filtered gets actively reabsorbed, right, through active pumping or osmosis or diffusion. So, and this is the important piece, it is reabsorbed osmotically. And that's a fancy way of saying that stuff in water gets reabsorbed at a rate that by the time it gets down to the end here, I did this drawing not perfectly. Hang on. By the time it gets down to the end of the proximal convoluted tubules, the osmolarity of the filtrate is 300. And then as you're moving deeper and deeper into the medulla, whoa, hang on. Well, that's wonderful. You're seeing a saltier and saltier environment. So 600, 900, 1200. Really what I want you to understand is that you move deeper and deeper into the cortex of the kidney. The osmolarity of the peritubular capillaries is going up. Do you follow that? There's more stuff and less water in the blood as you move deeper and deeper into the cortex of the kidney. All right? We'll just leave it at that. And these numbers will vary. All right?
Wait, no, where's water in the
Hang on. I'll get there.
When it goes back up, just go back up.
Yep. Hang on. Don't say nothing. I'll do it. I'll get it. So remember, as the stuff is filtered, the filtrate has an osmolarity of about 300 milliosmoles. And stuff and water gets reabsorbed back into the blood so that when it gets down to the end of the proximal convoluted tubules, the osmolarity of that filtrate that's in the elebic road is 300. You got me? I'm just going for it. Now watch. As you move deeper and deeper into the medulla, what's happening to the osmolarity? What's happening? It's going up. But what's the osmolarity of your filtrate as it's entering the descending limb of the loop of Don Henley? It's 300, right? What's the osmolarity here? It's 600, 900, 1200. So if the osmolarity is 300, and what's the only thing that can get reabsorbed in the descending limb? Water. So where's water going to go in this case? It's going to go from a lot of water and less stuff to an area of more stuff and less water. So in this case, water will get brought back into the blood by osmosis. And that water will move until the osmolarity of the filtrate is equal to the osmolarity of the peritubular capillaries. So now it's moving to 900, so water is going to get reabsorbed back into the blood. Do you follow? Until you get down to here where the filtrate now is going to be very concentrated with electrolytes and less water. Now you're going to move up the ascending limb. In the ascending limb, water is impermeable. So the only thing that can get reabsorbed is what? So you're removing stuff from the filtrate and bringing it into the blood. So what's going to happen to the osmolarity? It's going to go down. So each time electrolytes, more and more electrolytes get reabsorbed until the osmolarity is back to 300. Do you follow this? Then you have the thickened ascending limb. And in the thickened ascending limb, electrolytes are actively pumped back into the blood. So if you're removing stuff from the filtrate, what's going to happen to the osmolarity? It's going to go down. So you have a very, very dilute urine. A lot of water, not a lot of stuff. And then when it gets into the distal convoluted tubules, that will determine, based on hormones, whether you make a concentrated urine or a dilute urine. And in the absence of hormones, you always make a dilute urine. Yeah? How many people follow that a little bit? That's good. Okay. So, if you take the essay portion of the kidney quiz, then I'm going to ask you to be able to explain what I just explained to you. The multiple choice is looking better, ain't it?
So what about when you do vitamins? Because there's not hormones in vitamins.
No, the vitamins, they're actively filtered by the glomerulus, so they'll end up in the collecting tubules. And vitamins that are not reabsorbed back into the blood will be peed into the toilet. The fat-soluble vitamins, on the other hand, are stored in the liver. So D, E, A, and K are fat-soluble, so you can develop hypervitaminosis with the fat-soluble vitamins. The water-soluble vitamins, like the B vitamins, vitamin C, they're peed out into the toilet. That's why if you take a vitamin C in the morning, your urine's real yellow. Yeah? That's how that works. Okay, so that is the basic structure and function of the nephron. Just a couple of things. One of the things that the distal convoluted tubules do is they actively secrete drugs into the urine. So where you get rid of drugs, or the metabolites of drugs, is in the nephron, but it's specifically in the distal convoluted tubules. So as people age, their kidney and liver function goes down. So that's why in older people you have to watch the amount of medicine that they give you. You give them, because they can become toxic very quick. The liver cannot detoxify the medication as quickly, so the amount of drug, active drug, that ends up in their blood is higher, and they can't eliminate that drug as quickly because their kidneys are failing. So all drugs are metabolized in the liver and excreted by the kidney. That's why if a doctor is going to start a patient on a new drug, they will do blood tests that look at their blood urea nitrogen and creatinine, and they will also look at their liver function to make sure that their liver is working properly. And no, that is usually older people tend not to eat as much or drink as much, so they tend to be dehydrated. And because you don't void as quickly, as much, you don't empty your bladder as frequently, and that can, yeah. The other thing is that their immune system isn't as good as it was before, so they're more prone. And plus, they don't clean themselves as good. You know what I mean? They're old. You know, that's the way it works. Okay, so let's look at this for a minute. Bless you. All right. What I'm going to do for you now is I'm going to explain to you how the hormones work and how they affect the kidney. So the first hormone I'm going to explain to you is ADH, anti-diuretic hormone. And just to give you a couple of things, ADH, anti-diuretic hormone, has another name. It's called vasopressin. So if you hear vasopressin, then you know that you're dealing with ADH. Now, ADH is released from the posterior pituitary gland. The two hormones that are released from the posterior pituitary gland are ADH and oxytocin. Oxytocin. You got me? And it's released in response to an increase in osmolarity. So if you recall from, I think it was quiz number 1, right, when I talked to you about osmolarity, remember that? All right, so let's do this. And I'll give you a clinical example of why this is important. So this is the H-cell, and then you got the pituitary gland. Now, the reason that ADH and oxytocin are released from the posterior lobe of the pituitary is because they're actually synthesized in the H-cell first, and they're then released by the posterior pituitary. So there is a portal circulation that connects the H-cell with the pituitary gland. So watch. And I'll just go through this myself, right? So watch. If you are bleeding, your blood volume is going to drop, venous return is going to drop, the stretch, force of contraction, blood pressure. And if you recall, I explained to you that capillary fluid pressure is determined by your systolic blood pressure. Do you remember me saying that? I'll never forget it. So as capillary fluid pressure begins to drop because systolic blood pressure is dropping, at some point interstitial fluid pressure will become greater, and that will force fluid from the interstitial space into the capillary in an attempt to maintain blood volume. So in this case, you are decreasing the water, but the amount of stuff is staying the same. So if you're decreasing the water and the stuff is staying the same, that's going to lead to an increase in osmolarity. And when you increase osmolarity, that is going to trigger osmoreceptors, and it will cause the H-cell to begin the production of ADH. And ADH will then be sent to the posterior pituitary and released into the blood. Now, ADH's primary effect is on the collecting ducts. And if you look, watch, that's why I did this. I didn't do a very good job. But the collecting ducts start out in the cortex, and then they move deep into the medulla of the kidney. So observe. Here's the collecting ducts. You got me? And as you move deeper and deeper into the medulla of the kidney, the osmolarity progressively goes up. Now, this is very important. In the absence of hormones, the collecting ducts are impermeable to water. But in the presence of ADH, and ADH was released because the osmolarity of the blood, right, went up, right? So the osmolarity of the interstitial fluid went up as well, and that stimulates osmoreceptors. Now, just if you think about it intuitively, if you're bleeding, do you want to be peeing a lot? Good. So what happens is ADH will actually stimulate the cells that make up the collecting ducts to insert water channels into the collecting ducts. And this will cause water that was normally going to get peed out to get reabsorbed back into the blood. And the higher the osmolarity goes, the more ADH is secreted, and therefore the farther down the collecting ducts those water channels are inserted. And as you move farther down, the osmolarity goes up. So that means if you have water channels way down in the collecting ducts, much more water is going to get reabsorbed. So under maximal ADH secretion, you produce no urine. Do you follow that? Now, when you drink alcohol, alcohol actually prevents ADH from inserting these water channels. In your book, these water channels are called aquaporins. So alcohol prevents ADH from doing that. So if you can't insert those water channels, can you absorb that water back into the blood? So when you drink, you pee a lot. And if you remember when you were drinking, that your first pee had a little color to it, but your subsequent pees after that are clear. And that's because of alcohol's effect on ADH. Yep. And just so you know, it doesn't matter the type of alcohol. It's the amount of alcohol. So if you drink shots versus beer, you may pee a little more with the beer because you're taking in more volume, but over the long haul, it's the alcohol effect, not the volume.
Well, how come when you drink a lot of water, your pee is clear? I always thought it's because the water diluted it.
Yeah.
Is that what it is?
Yeah. If you think, what happens to the osmolarity of the blood if you drink water? If you say the opposite, you'll be right. Okay, good. Good. Where is that? You're chronically dehydrated. Yep. That's why you wake up with cotton mouth?
Do they mainly die from renal failure then?
No, they die from liver failure. Or they drive off a cliff because they're loaded. Or GI bleed. That's how they die. Watch. What was the stimulus for the release of ADH? An increase in osmolarity. So remember, you always have a little bit of this stuff circulating, right, with normal physiology. But if your osmolarity goes down because you're drinking water, that is going to suppress the release of ADH. With the suppression of ADH, you're not going to insert those water channels, so you're not going to reabsorb that water, so that excess water gets peed out. Yeah, it does. It's incredible that way. I got it, So yeah. Follow that? Okay. That's ADH. ADH also has some vasoconstricting properties. That's why it's called vasopressin in England. So if you plan on going to England and maybe picking up some vasopressin, don't say ADH because they won't know what you're talking about. But all right. Have you ever heard of a condition called diabetes insipidus? No. No. It's in the book. They don't make any. The most common cause of diabetes insipidus is a tumor of the pituitary. It's benign typically. Then there's another one called syndrome of inappropriate ADH, which is the opposite, basically, much. All right, that is anti-diuretic hormone. Yeah?
If you were to continue not urinating,
I have to go now.
you know, you
What?
don't.
Flu or
I
cold
don't know,
or
but
something?
whoever has it better not bring them in.
I know, that's what I'm saying. I'm like, y'all better stay away. I've been sick enough this
You're
year.
certified anytime or clinicals or anytime until you do.
What's that?
Do you have to be CPR certified at the time of clinicals or petition?
Petition.
Is it petition?
They technically tell you to take it with anatomy and anatomy. That's what I was told. Even if you just re-up it.
It's gonna run out.
I'm,
Because sometimes it takes that 2-year process during petitioning, they say. So that's why they say to do it before petitioning.
I'm a CPR instructor.
Are you?
Yeah, I just got my renewed a couple Fridays ago.
Are you doing your EKG class this summer?
No.
Really? Are you doing
No.
any classes this summer?
I'm doing a pathophysiology and an anatomy class. Or an anatomy. All right. Okay, watch. What's the afferent arteriole made out of? That's good. What are the two things a muscle can do?
Relax.
Good. Where does arterial blood always go? That's right. So watch. Yeah. Watch. If you look, well, I'll just use this. If you're bleeding your own blood, do you want to make a lot of urine? One of the ways that you make urine is based on your blood pressure. You got me? Pressure diuresis. So if your blood volume is low, watch, if your blood volume is low, then, watch, the afferent arteriole constricts and the efferent arteriole dilates. So what will happen to pressure in the glomerulus? It will drop. So one of the ways that you form urine is by simple pressure in the glomerulus. So if the pressure in the glomerulus drops by constricting the afferent arteriole, so less blood is going there, and dilating the efferent arteriole, pressure in the glomerulus drops, so urine output drops. So, and what controls that is the nervous system, right? Sympathetic stimulation. Yeah? Okay, so we covered ADH. Yes? All right. And what's important to note is that the reason ADH is released is because of an increase in osmolarity, right? So elevated or decreased, did I say decreased osmolarity? Increased osmolarity. So in response to a decreased osmolarity, that's going to have a negative feedback on the pituitary gland and prevent the release of ADH. You got me? So the other hormone that affects the nephron is aldosterone. So I'm going to explain to you now the renin-angiotensin aldosterone mechanism. This in your book is called RAS, the renin-angiotensin aldosterone mechanism. All right? So if you recall, one of the things that the kidney does is it monitors long-term blood pressure. All right? So watch. I tried to explain the juxtaglomerular apparatus one semester, and people's heads literally exploded. So I'm going to go away from that. Now watch. Anything that causes a drop in blood pressure in the afferent arterial is going to cause activation of the renin-angiotensin-aldosterone mechanism. Now watch. Do you see these little cells here? These teal-colored cells? Do you see that? These cells are called juxtaglomerular cells. Juxta means next to. So they're next to the glomerulus. And these guys, these cells, very important, they respond to stretch. Now watch. Think of the afferent arterial as a bike tire. If there's less pressure in the bike tire, what's the afferent arterial going to do? It's going to collapse. And when it begins to collapse, it's going to stretch those juxtaglomerular cells. Why was the afferent arterial flat? Because the blood pressure through the kidney was low. And that's going to cause a stretching of these juxtaglomerular cells. In response to stretch, they release into the blood an enzyme called renin. Renin is an enzyme. What do enzymes do? I'll tell you. They catalyze chemical reactions. Are you with me? So here we go. Continually produced by the liver and in its inactive form is a chemical called angiotensinogen. Anything with gen after it equals inactive. So this is continually produced by the liver and dumped into the blood. What you have now circulating in your blood due to the drop in blood pressure in the kidney, you have renin. And what renin will do is it will activate angiotensinogen into the active form called angiotensin 1. And angiotensin 1 circulates in your blood for about 30 minutes. And what angiotensin 1 does is it is a mild arterial vasoconstrictor. And if you recall from our study of the cardiovascular system and Ohm's flow law, if the arteries of your body get smaller, resistance to arterial blood flow goes up, and therefore systolic blood pressure has to go up to maintain Q. Yes? Now, in that time, angiotensin 1 is circulating, and in the lining of the pulmonary capillaries, there is an enzyme called ACE. Angiotensin converting enzyme, ACE. And ACE takes angiotensin 1 and converts it to the much more powerful angiotensin 2. Angiotensin 2 is a massive arterial vasoconstrictor. So it's going to take arteries that were mildly constrictive and massively constrict them down. So what's going to happen to resistance to blood flow now? It's going to go up even more. So what's going to happen to your systolic blood pressure? That's going to increase. Now, angiotensin 1 lasts about 30 minutes. Angiotensin 2 can last for days. But its most powerful effect and long-lasting effect is on the cells of the adrenal cortex. If you recall from our discussion of hormones, I explained to you, and I will never forget it, I explained to you that cortisol, aldosterone, and DHEA are released from the cells of the adrenal cortex. Do you remember our discussion of that? It was very lively. So the cortex is the outer portion of the adrenal gland, and you're not going to believe this, but embedded in the cells that make up the adrenal cortex are receptors called angiotensin 2 receptors. Oh. What do angiotensin 2 receptors recept? Angiotensin 2. And when angiotensin 2 binds to angiotensin 2 receptors on the cells of the adrenal cortex, it causes released into your blood the hormone aldosterone. You got me? Aldosterone exerts its effect on the distal convoluted tubules. And you're not going to believe this. This is sickening. On the cells that make up the distal convoluted tubules, you have, embedded in them, in the cells that make up the distal convoluted tubules, you have aldosterone receptors. Somebody stop me. Yeah? Watch how beautiful this is. And when aldosterone binds to aldosterone receptors in the distal convoluted tubules, it stimulates in those cells the sodium-potassium pump. And it will take 3 sodiums that were going to get peed into the toilet, and it pumps them back into the blood. And when sodium moves from the collecting ducts back into the blood, what is going to follow the sodium by osmosis? The water. And at the same time, it will pump 2 potassiums that were in the blood into the collecting ducts for you to get peed out. Are you following? So under the effects of aldosterone, what will happen to your blood pressure, or your blood volume? And what will happen to venous return? Stretch, force of contraction, blood pressure. What's going to happen to urine output as a result of aldosterone? It will what? Right. So you are increasing your blood volume but decreasing your urine output. Do you follow that? Right? And that makes sense. Why was the renin-angiotensin-aldosterone mechanism stimulated? Because of a drop in blood pressure in the kidney. So one of the ways that you can increase your blood pressure is by increasing your blood volume. Do you see that? Now, this is very important. If you recall, I explained to you that hydrogen ions and potassium ions have to be actively secreted from the blood into the urine. And the only way to get rid of potassium is through aldosterone. It has to be pumped out. So anything that would cause a drop in aldosterone or aldosterone's ability to produce its effect is going to cause a buildup of potassium in the blood. Do you see this? So, that is the renin-angiotensin aldosterone mechanism. Have you ever heard of drugs called ACE inhibitors? Have you heard of those? When you get into clinical, they're going to explain those. But I'll explain it now. What do ACE inhibitors inhibit? Good. That's pretty much my explanation. By inhibiting ACE, what is not converted to angiotensin II? How long does angiotensin I last? So, angiotensin II causes the release of aldosterone and the subsequent reabsorption of sodium and water into the blood. So if you take an ACE inhibitor, you don't have the effects of aldosterone. You also will not get arteries massively constricting, so instead, the arteries will dilate. So if the arteries dilate, what happens to resistance to arterial blood flow? It will go down with the subsequent drop in systolic blood pressure. So ACE inhibitors, ACE inhibitors typically end in ill, like Vasotec. Captopril, lisinopril, minoxidil. Have you heard of those? You did today. Those are ACE inhibitors. Isn't that special? One of the problems with ACE inhibitors, I'm not going to get into the chemistry, but where is ACE? I'll tell you. It's in the lining of the pulmonary capillaries. So one of the common side effects of ACE inhibitors is a dry cough. And people don't like to cough. It's bad for them. So really smart people with tape and pocket protectors, they came up with a new drug. That's an artery. And you're not going to believe it, but the cells that the muscle cells of that artery have embedded in them angiotensin II receptors. And when angiotensin II binds there, what does it do to the artery? It massively constricts it. Ain't that right? You also have angiotensin II receptors on the cells that make up your adrenal cortex. See, right there. So, instead, watch it. Instead of inhibiting ACE, what they decided to do is angiotensin II would be made, but it couldn't exert its effect because they would give them a new medicine called an angiotensin II receptor blocker. And it blocks, oddly enough, angiotensin II receptors. So if angiotensin II cannot bind to the receptor, can it cause massive arterial? Nope. Will it cause the release of aldosterone?
Oh, no.
No, because you blocked it. So you will pee more, right? You got me? And your arteries will dilate, both subsequently lowering blood pressure. Those are referred to as, you're not going to believe this, angiotensin II receptor blockers. And they're abbreviated as ARBs. Have you ever heard of ARBs? Have you ever heard of Cozar? Losartan? Those are angiotensin II receptor blockers. Yeah?
Why are some people prescribed ACE inhibitors and some people prescribed beta blockers?
It depends on their pathology. Let me give you an example. In congestive heart failure, beta blockers, in a dilated form of congestive heart failure, beta blockers are contraindicated. So to lower the blood pressure, they're given ACE inhibitors twofold. Number one, it reduces their blood volume, so it has a diuretic effect, which is good for you when you have congestive heart failure. And it doesn't affect the force of contraction of the heart like a beta blocker would or a calcium channel blocker. So it really depends on the pathophysiology. So people who have just high blood pressure and they're young and healthy but they have high blood pressure, they are usually given diuretics because those have the least amount of side effects. And then there's milder forms of diuretics rather than loop diuretics. There's hydrochlorothiazide. Have you heard of this? That prevents sodium from being reabsorbed in the distal convoluted tubules, so the diuretic effect is much lower. You follow? Okay.
I have a question.
Yeah.
I don't know if I'm going to say it right, but I have a patient who was on Lasix and then had a 20-pound weight gain.
Mm-hmm.
So the Lasix wasn't working. They upped it, but it didn't work. They added spinolactone.
Spirolactone.
That.
Or spironolactone, yeah.
She dropped it within a week. She peed it all out.
Yeah.
Is that the same essence of that?
Yeah, spironolactone is a potassium-sparing diuretic, and it works on the distal convoluted tubules. Also, spironolactone blocks testosterone production in the testes. So that's why people who are going through gender reassignment, if they're a guy going to a girl, they're given spironolactone to block the production of testosterone in the testes.
Where else is it block testosterone?
In women,
If it's prescribed for female hormonal acne.
That's what my patient's female. That's it.
I don't know. Yeah. Did you guys get together and at break and knew that you were going to ask me a question that I had no idea? Is that what you
She
did?
just told me today to call the nurse and have her order more, but that's what you think of it.
Yeah, a lot of times they will use multiple forms of diuretics, and there's another diuretic called aldactone. Have you ever heard of aldactone? Aldactone blocks the effects of aldosterone in the kidney. So aldactone is a potassium-sparing diuretic.
So I take diuretics under home. Do diuretics medical names under home?
Yeah. Or mide. Yeah, furosemide, aldactone, spironolactone, Tommy Two-Tone. Jenny, who can I turn to? Okay. That's the renin angiotensin aldosterone mechanism. See, yeah. Can I show you something clinically? Would you like to learn this? Okay. All people with a dilated form of congestive heart failure are on ACE inhibitors. Here's why. And you can take this for whatever it is absolutely worth. But when you have someone who's in congestive heart failure, they can spiral out of control rapidly. And that is due primarily to the activation of the renin-angiotensin aldosterone mechanism. Now watch. In people with congestive heart failure, does your kidneys know that you had a heart attack and that your heart ain't beating so good? Nope, doesn't. All it knows is that the blood pressure in the kidneys is down. So you're going to activate the renin-angiotensin aldosterone mechanism. And we'll just cut to the chase. That increases your blood volume, and watch it, it increases resistance to arterial blood flow, or afterload. So it increases preload and afterload on the heart. You got that? Two things you simply don't want if you have congestive heart failure. Because you have more venous blood coming back to the right side due to the effects of aldosterone. Right side, no problema. That means no problem in Spanish. So the right heart's going to stretch, line up those going to contract real good, send more blood to the lungs. Ain't that right? But the left heart, well, unfortunately, that's as good as it gets. So if you add more blood back to the left heart, you're going to overstretch it. So what's going to happen to the force of contraction of the heart? I'll tell you. It's going to go down. So if you decrease the force of contraction of the heart because you overstretch the heart, what's going to happen to the person's blood pressure? It's going to go what? Yes, good. And when the blood pressure goes down, it's going to be sensed by the kidney, and the kidney's going to release more renin. And it's going to activate the renin and these people will spiral out of control rapidly.
Would you ever see someone be put on both of them in conjunction, the ACE inhibitor and the ARBs?
Sometimes, yes. Sometimes. If they have a high dose of ACE inhibitor, then it's more likely they will get the cough, so they will throw in a little bit of an ARB. Do you see that? That's why when people are having an exacerbation of CHF and it's getting worse, it goes downhill rapidly. So by the time you come back from updating your Facebook status, they're taking a 6-foot dirt nap, or they got the death rattle and it's too late for them. And you know who will explain that to you? They're going to read a PowerPoint to you. And God bless you. So, see, now you can go back and explain it to them. And I'm sure you will. Okay. All right, so watch. Watch. You have the renin-angiotensin-aldosterone system and ADH increase your blood pressure, both from different mechanisms, both from different stimuli. One is due to an increase in osmolarity of the blood. The other is due to a drop in blood pressure or blood flow in the kidney. Say yeah. There is a hormone that is released from specialized cells in the right atrium. That hormone is called A&P. Stands for atrial natriuretic peptide. What does nature mean? Nature. What does that mean? Come on. Come on. What? I'm going to give it to you now. Ready? What's the chemical symbol for sodium? What does diuretic mean? What does a diuretic do? Makes you pee. What do you think natriuretic means? You pee salt. And if you pee more sodium, what's going to follow the sodium by osmosis? That's right. Ready? Here we go. Here's looking up your old address. If you increase your blood volume, what happens to venous return to the heart? It goes up. And if you add more blood back to the right atrium, what do you do to the right atrium? You stretch it. And in response to a stretched right atrium, those specialized cells release into the blood A&P. Atrial, because it comes from the atria, natriuretic peptide. An atrial natriuretic peptide circulates in the blood. Watch it. And it has its effect on the distal convoluted tubules of the nephron. And guess what A&P does? It's right there, right at you. Oh, yeah, okay, fine. It inhibits the sodium-potassium pump of the distal convoluted tubules. So will you pump sodium from the distal convoluted tubules into the blood? So that sodium will remain there, and what will follow that sodium into the toilet? Water. What will happen to your blood volume? What will happen to venous return? What will happen to the stretch of the right atrium? So there will no longer be a signal to release A&P into the blood. Another example of a negative feedback mechanism. I'm bringing this all home for you, ain't I? Here you go. So watch. Watch. A&P, atrial natriuretic peptide, is the only hormone in the body that lowers your blood pressure. All other hormones. So clinical trials are underway to give A&P to people who want to be in nursing. Did you catch that? It took you a while. To people with high blood pressure. Hypokalemia. You could, but it'd just be better just to give them potassium. just to supplement them with potassium. Potassium's dangerous. Got to control that. Okay, watch. I guarantee you, and I give you my word, that this will come back and haunt you in clinical. And if you never hear this again, you can come to me and say, Tim, you lied, right? And I will give you $50 in cash. So pay attention to this. Mark this down. Refer to this tape that I've put on on YouTube, and it will be there in perpetuity. So at any time, maybe I'm 82, 83, and you're still in clinical, because you flunked health alterations for the 19th time. Yeah. Yeah. Okay. Watch it. Watch it. One of the ways that you can monitor congestive heart failure in patients is with a blood test called BNP, brain natriuretic peptide. The reason it's called brain natriuretic peptide is it was first isolated in sheep's brains. Watch it. The only time brain natriuretic peptide is released is if your ventricles are overstretched. So overstretched ventricles will release into the blood BNP. Who's got overstretched ventricles? CHF people. You got an overstretched ventricle? No. Are you going to be releasing any BNP? And the more BNP that is released, the more your ventricle is overstretched. So if someone comes into the hospital, again, Spanish for hospital, and they're complaining of shortness of breath, and a doctor wants to know, is this pneumonia or an exacerbation of their CHF, they will draw a BNP. And if it is elevated, they now know it's related to their CHF. And what?
What does BNP do for the ventricle release?
Does the same thing as A&P. Do you see that? That will, I can see it. I see it. And if you get that wrong, all I can say to you is, I told you so. I had this one student, a year ago, she's in clinical now, right? And she didn't do good in the class. She was an EMT, so she thought they know everything. And I saw her in the hallway, and she goes, Tim, I flunked health alterations. And you know what I said to her? I told you so. That felt so good. It did. I know that's evil, but it felt good. If you listen to this, right? If you listen to this, yep. If you listen to it, I'll give you extra credit. Okay? Will you listen to it?
Right now?
Yeah.